Good afternoon, everybody, and welcome to the final session of the Monday, the final or second last day of our conference. And we really appreciate you staying the distance and being with us. This is the second iteration of our glaucoma bootcamp. The first we presented at RANZCO in February this year, and this year we're delighted to actually have the luxury of live polling. I'm sure all of you are now familiar with it, but for those who aren't, please log into our session, or this session, on your app and go to the bottom and do live polling. When the slides come up, the AV support will be putting the polling sessions up. If I could have my first slides. I would like to start this session by acknowledging the traditional owners on the land on which we meet, the Royal Australian New Zealand College of Ophthalmologists. Members and participating guests wish to acknowledge the Aboriginal and Torres Strait Islander peoples of this country, sovereign custodians of country. We acknowledge their continuing presence and their contributions made to the college and to the communities we work in. We will respect past elders and communities and will continue to live, work and interact in a respectful manner with present and future leaders and communities. The RANZCO Reconciliation Action Plan reflects the message of its First Nations engagement. Next, it gives me great pleasure to introduce our panel. This is a diverse group of glaucoma specialists from around Australia, New Zealand and the world. My name is Catherine Green. I'm a glaucoma specialist based in Melbourne and head of the Royal Victorian Eye and Ear Hospital Glaucoma Unit. The speaker who will follow me is Dr. Bernardo Soares, who did his ophthalmic training in Brazil and has done first a glaucoma fellowship and a cataract fellowship, and is based in Melbourne too. Nicholas Tolster hails originally from Queensland, did his training in Sydney and has dual corneal and glaucoma fellowships and is now based back in Brisbane. Apana Raniga hails from originally across the ditch, based now in Sydney and has dual uveitis and glaucoma fellowships. Dr. Alp Attic, originally from Sydney, now based in Melbourne, has dual glaucoma fellowships, one in Melbourne, and he, at the height of the COVID pandemic, went to Alabama under great difficulty and hardship and completed a fellowship there. And finally, it gives me great pleasure to introduce Janie Wiggs, who by now I'm sure you're all familiar with, an esteemed guest speaker for our conference and a pioneer of glaucoma genetics. Janie has always been someone that I've admired, having started my ophthalmic career in glaucoma and genetics as well through the Glaucoma Inheritance Study in Tasmania. So the aims of this session are to provide a practical and case-based refresher on diagnosis and management of glaucoma. The secondary goal of this is also to demonstrate examples of formats and tools that promote adult learning. I'm going to start with a case that I saw last year in the middle of a COVID pandemic. He was a 91-year-old man who was surprisingly fit. He looked probably 75 and had no other problems apart from his pseudo-exfoliative glaucoma, which he'd had for many years. He presented with 3 to 4 months of symptomatic progressive decline in vision, and he was referred to me for a second opinion at his request, having been told by his treating ophthalmologist, who had been very attentive and caring, that there was nothing more that could be done for him. At his first visit, his visual acuity was 636 in the right eye, 618 in the left. His IOPs were 36 mmHg in the right eye and 28 in the left, and he was on Zalacom, Simbrinza, and Saflutan. He had not had previous SLT, and these were his fields. Interested to know how things had been over the last few months or years, I requested fields from the referring ophthalmologist. No fields had been done for 3 years. And this is what his vision had been like when he was 88. It's not such a sad story. He's now 18 months post-bilateral trabeculectomy with really well-controlled intraocular pressures, and he's also had some visual recovery. But this is really a sobering case, and I think it illustrates some important take-home points, that pseudo-exfoliative glaucoma can progress rapidly even when it's been previously stable. We need to actively manage IOP. duplicating a prostaglandin analog does not result in improved IOP. SLT, in this case, may have been helpful. And more frequent field testing, especially as the IOP started to rise, may have enabled earlier intervention. I know there are lots of barriers to field testing, particularly as patients dislike it, but it really is important. And the final thing is, refer on when you're not winning, because it's much easier to say things earlier in the day. The objectives of this session are to evaluate risk factors and clinical findings in treatment versus observation of glaucoma suspects, allow you to tailor strategies for monitoring for progression to the individual patient, discuss the pitfalls of medical treatment and apply strategies to reduce ocular surface disease, identify angle closure patients and apply evidence in managing decisions in treatment, and finally, to critically appraise the current evidence for the use of MIGS in glaucoma management. And as I said, there's also a teaching and learning aspect to this. So I would like you to be able to take away from this some principles of adult learning and instructional design in your teaching. The outline is, I'm going to start off with some cases about when to treat and not. Bernardo will then talk about progression and target IOP and how we monitor using structure and functional testing. Nick will talk about the pitfalls of medical treatment. Aparna will take us through the latest evidence in angle closure management. And Alp Attic will pose the question of whether we should be early adopters and review the evidence for minimally invasive glaucoma surgery in 2022. My wrap-up will include some highlights of teaching and learning and things that we can take to our own teaching and learning practice, followed by Q&A, and I'm sure Janie will be an active participant in that. So, some interactive questions. The first is, who are you? Are you a general ophthalmologist, a glaucoma specialist, other subspecialist, a registrar, a fellow, or an allied care professional? And if we could start the polling, please. Is the polling closed? I can't see the AV people. Still changing. So, a great mix of people, but as we would expect from this conference, a large number of general ophthalmologists. And this is highly relevant because most glaucoma in Australia and New Zealand is managed by general ophthalmologists. When monitoring for progression in a glaucoma suspect, what testing do you routinely perform? Visual fields only, OCT only, OCT and fields, disc photos, OCT and fields. Very pleasing to see that the majority of people are using both structure and function. If you have a disc camera available as well as an OCT, I find color disc photography extremely useful. In patients with newly diagnosed glaucoma, how often do you perform visual field testing? Annually, 6 monthly, 4 monthly, or 4 monthly to start, then 6 monthly when stable? Still moving around a bit. That's excellent. So the evidence shows that when you see someone newly diagnosed, you don't know really where they are when they started. So you really need to establish a rate of progression before you can comfortably say that they're stable. A recent change to the Medicare benefit schedule allows you to do 3 fields in an annual time period, which has greatly enabled the recommended testing frequency. What is your first-line treatment for newly diagnosed open-angle glaucoma? Timolol, a prostaglandin analog, SLT, a fixed combination, or do you offer the patient the option of SLT or prostaglandin analog? So a fairly even mix of prostaglandin analog as first-line treatment or the option of SLT. In my personal practice, a newly diagnosed glaucoma patient often has a lot to take in, and I will often start them on treatment, mention SLT as an option, and discuss that in more detail at the follow-up appointment. True or false? Cataract extraction alone is frequently effective at lowering IOP. Probably should have a third one, it depends, but you don't have that option. That's excellent, and you'll be paying attention in Aparna's talk. We're talking now about side effects from eye drops. How much of a problem are they in your practice? Never, just occasionally, maybe once a week, quite frequently, or every single patient?
Close to.
I don't know if that question's come up in the polling. No, might move on. How often do you perform gonioscopy? Routinely on all patients, routinely on all glaucoma referrals, only on angle closure suspects, only if you really have to. Patients hate it. I prefer anterior segment OCT, or if it's suspected narrow angle, I hate gonioscopy so much I'll send it to someone else. Are you really being honest? Is the ideal world versus the world in practice. Anyway, I think that's really great. Final question before I move on to the next stage is, what is the minimum level of evidence you seek prior to adopting a new treatment? The new technology for youth in my country looks promising, and I'd like to give it a try. Expert opinion, my colleagues are starting to use. Case reports or series, a retrospective cohort study in a good journal, randomized controlled trial, or systematic review meta-analysis. Please be honest. I think you may have been. So thank you for your participation. There will be some more polling questions that are relevant to our talks. So I'm starting off now thinking about glaucoma suspects, and that involves a lot of patients that are referred to me, usually seen by an optometrist. And my job is to decide whether they have glaucoma or not, and then make a decision of whether I commit them to a lifetime of treatment. The objectives of this section are to use evidence to support clinical decision-making in the management of glaucoma and glaucoma suspects, and to encourage you to think about avoiding both over and under treatment. Case 1 is a 58-year-old man. The optometrist referral was as a glaucoma suspect, based on both his intraocular pressure and disc appearance. He is a 6-diopter myope and has fairly thick corneas. These are his OCTs and fields. Did you have long enough to look at them? Pressure's 22. So, would you discharge him to optometric care, monitor for progression, or commence treatment? And if we could have the polling, please. This audience is not committing people to a lifetime of treatment that they do not need, but is there any additional information that you need? So, factors influencing your decision. I deliberately didn't give you the IOP. His pressure was 22, as I said, but he has thick corneas, so that doesn't really leave us as an IOP. It's not really helpful in decision making. His discs are difficult to assess in myopia because the OCT is often abnormal. He's a relatively young patient and he has full fields. However, disc examination was highly suspicious. And I looked at his first disc, his left disc first, and I thought it really looked abnormal. It didn't look like a normal myopic disc. And then I moved over to his other eye, and it was the disc hemorrhage that made the decision, tips the balance. The evidence for this is both from the collaborative normal tension glaucoma study and the early manifest glaucoma treatment study that IOP lowering is effective in slowing progression. And in the CNTGS and OATS, disc hemorrhages are strongly associated with progression. Case 2, a 52-year-old woman. She'd recently returned from living in the UK, and she had been diagnosed with probable glaucoma and been commenced on Xalatan, but she'd run out of drops in the move and hadn't made contact with an eye care practitioner. She was a low myope, about a -1.5. She had an average corneal thickness and normal pressures of 15 and 14 and no systemic risk factors. These are her OCTs. Ganglion cell complex. And these are her fields. So, same question. Would you discharge to optometric care, monitor for progression, or commence treatment? So, the majority of people are concerned about that field defect, and it does match the disc appearance. Additional information to change your decision. These are her disc photographs, and they are asymmetrical, but clinically I felt that the neuroretinal rims were quite healthy, especially if you compare it to the previous patient. I discussed with the patient what her preference was, and she really preferred to not be on drops. She was very adherent with attending appointments, and we made the decision together to observe her. The other useful bit of information is she had fields from previously that were not Humphrey visual fields, but there hadn't been much change in the interval that she'd been monitored in the UK. And so we elected to monitor her, and we've been doing 3 to 4 monthly fields since I first saw her with no evidence of progression. So the take-home points are: structure and function must match. Not all abnormal discs or OCTs mean glaucoma. Just be careful of red disease with OCTs, particularly in myopes. The clinical assessment of the disc is critical, and don't just rely on OCT. So even if you don't have a disc camera, dilate the patients and have a good look at their discs. As I said, I find disc photos extremely useful in monitoring for progression. Tilted discs can cause field defects. Even if they match the disc, that doesn't mean that they're glaucoma. And remember that glaucoma is a progressive optic neuropathy. So if you're monitoring someone and you're assessing them frequently enough, you will detect progression before it becomes visually significant for the patient. The important thing of this is to repeat field testing frequently enough to establish the baseline rate of progression and to detect if one of these people is a fast progressor. And finally, avoid overtreatment, because as Nick will highlight, the burden of disease is actually quite significant for patients. The burden of treatment is significant. And I now introduce Bernardo, who's going to take us to monitoring for progression using structure and function.
Thank you, Kathy. So we're going to cover progression, which is a big topic in a very short talk, but we'll make sure that we'll cover the main things through structure function, the rates of progression, as well as some factors affecting progression. Then I'll talk you through a main case that I've tried to cover all the bases. So with progression and structure function, we always want to look at the patient as a whole, gather all the clinical data, the pressure, the corneal central thickness, the visual fields, all the parameters on the OCT, and correlate all the information we have. This is a retinography of a patient that has a retinal nerve fiber layer defect. If you don't trust me, sometimes we do get a retinography that's not great quality, but you can see a Hoyt sign there, and they have an inferotemporal retinal nerve fiber layer thinning, which matches their supranasal visual field defect. But if we do forget to look at the retina, we would have missed a chorioretinitis scar that would have explained the visual field defect. So we know that OCT can detect glaucoma early in the disease, in the asymptomatic stage, and then the visual fields normally follows that structural change. The structural change can occur in average 4 years prior in about 35% of patients, but about half we can pick it up 2 years earlier, and we can make the diagnosis of glaucoma before they have any functional impairment with OCTs, even 8 years prior to their disease. We can do the same thing with the macula. The trend analysis is very good in assessing progression. Now, the rate of progression on OCT and visual fields is different. We can see OCT changes in the average retinal nerve fiber layer as up to 1 microns a year, as a slow, up to 2 moderate, and then fast. That's for a trend analysis. If we're doing an event-based analysis, we a bit more lenient with the inter-test variability. The same thing with the visual fields, but overall, we've got slow, moderate, fast progressors with different decibel rates of progression. So we're going to go to the case, which is a 54-year-old lady with primary angle closure glaucoma, which we're not going to discuss too much because that's Aparna's talk. But this is a real-life case. So this is a case from the eye near in Victoria. Patient had bilateral iridotomies in 2008 and a left phaco trab combined phacotrabeculectomy in 2014. So she's got 618, but amblyopia on the right eye with a pressure of 18 on maximum tolerated topical therapy there with GAN4 and Simbrinza, a thin pachymetry, occludable gonioscopy, but with no peripheral anterior synechia, and she's got a cataract. On the left eye, she's had the phaco trab, and her pressure is 20. So we're looking at her OCTs and visual fields. We can see that she's got inferotemporal thinning on the OCT on both eyes. On the right eye, the GPA, you can assess that she's progressing on the visual field, whilst the left eye seems relatively stable. So we look at the back of the eye, we can note the disc hemorrhage on her left eye, which is the eye with the stable visual field. So right eye has visual field progression. The left eye was stable, but the disc hemorrhage were present. We established that the pressure was above target, as it was 22, and we decided to start drops on the left eye. So my question for you is, with the right eye, so this is primary angle closure glaucoma with an early to moderate visual field defect, an early cataract on a patient with amblyopia, and a pressure of 18 on maximum tolerated topical therapy. What would you do next? If we could have the first polling question, please. So would you try and do SLT on that patient? She has a PI. Would you do cataract alone, cataract with a mixed procedure, or a combined phacotrabeculectomy? So results coming in between phaco alone and phaco mix at this stage. So this patient had cataract. We can go back to the slides, thank you. She had cataract alone, was continued on maximum tolerated topical therapy. Her pressure prior to the operation was 18 and now it's 15, so slightly better. Visual acuity improved somewhat, and her angle seems not to be compromised. The left eye, as I mentioned, we just added Gamfort and her pressure dropped slightly. So a year's passed, we've got the visual field on the right eye, which I didn't give you the GPA this time, but you can note there is definite progression, at least on that test, and the left eye seems stable. Although, we look at the fundus, there's another disc hemorrhage on her left eye. The left eye, again, with presumed stable visual fields, with a disc hemorrhage, pressure still above target of 18, since we know that it's very likely that the patient is progressing. That blebs failed, we've already given her Gamfort, and we're now going to give her Simbrinza, since that's the combination she is on the other eye. The right eye, however, showed visual field progression again. She's now pseudophakic. What should we do? Her pressure is 15. She's on maximum tolerated topical therapy. We can go to the polling, please. So we've got standalone MIGS, a trabeculectomy, a tube, or a bleb procedure like a Zen or a pressive flow. Remember, her visual field now shows quite advanced damage. So the polling results coming in, everyone's opting for a bleb-related procedure, but the trabeculectomy beating the other two devices at this stage, which, being at a public hospital, is exactly what she has. We can go back to the slides, please. So she had a trabeculectomy in April and had extra drops on her left eye. Her pressure was then 8 on the right eye, 13 on the left. You can see her OCTs, which done at that time, which at this stage, to the point that Kathy's made, that sometimes the OCT is not quite reliable and not everything red is disease. You can see on the right eye, on the retinal nerve fiber layer, she has a posterior vitreous detachment artifact. And on the left eye, on her ganglion cell complex, on the right eye, there's a segmentation artifact there. So this is her GPA post-TRAB on the right eye. And you can see that the final 3 visual field tests, they've shown some improvement of the VFI, and then some instability after she's had the trabeculectomy. Whilst the left eye, even though there's inter-test variability, and she's had those disc hemorrhages and escalation of her therapy, she's remained reasonably stable or a very slow progressor. So this is the final follow-up. Patient's quite stable 2 years down the track. So what we want to do with progression is consider whether or not that progression is related to aging loss, neurodegenerative disease, compare with the severity of disease and the number of tests. So we'll get into that. With age-related changes, we know even with the normative databases on the OCT that we'll get thinning of the retinal nerve fiber layer, average number throughout years. A few studies have looked at that, but it's safe to say that overall progression of 0.92 per year or greater would mean that it's extremely likely, 95% likely, that these patients are progressing above the age-related changes. We also know through good data from meta-analysis that retinal nerve fiber layer thinning has been observed in patients with neurodegenerative diseases. So we should consider that in our older population, which is most of the glaucoma patients we see. So takeaway messages from this talk are to correlate all the clinical information. If you have a number to take home from at least my bit today, would be 0.92 a year of the progression on the average retinal nerve fiber layer on the OCT trend analysis. Consider the age-related loss, the neurodegenerative disease, and if the patient has been recently diagnosed, the disease staging to the progression, where we're going to do visual fields a lot more frequently later in the disease, and OCT more frequently earlier, and the frequency of those tests, considering the inter-test variability, to get a good event-based and trend-based analysis. Thank you.
I'd now invite Nicholas Tolster to discuss Is More Really Better? Pitfalls of Medical Therapy.
Thanks, Bernardo. So I've been asked to talk to you today a little bit about the treatment options available in terms of keeping our patients relatively asymptomatic. You're all aware that the treatments that we provide in glaucoma come with their own cost, both in terms of treatment burden, but side effects. And I'm a strong believer that those side effects can often be the limiting factor in terms of what's successful and what's not for treating glaucoma. So if we can make some smart decisions, both in terms of what's effective, but also what keeps our patients happy, we're more likely to have success. So I'll take you through just some touch points. There's really no time today to get into depth of each of these issues, but I'll just sort of hopefully do some consciousness raising about a few separate issues that I thought worthwhile mentioning, and perhaps that'll be something that you can take home and have a bit of a think about. So let's have a little chat about what the harm that the various treatments we prescribe may cause, what some strategies to minimise that harm might be, and then I'll just take you briefly through how I treat ocular surface disease, just my personal approach, and then feel free to adjust that for your own practice. So this was a 66-year-old lady who came to me in the last year or so. She was escaping lockdowns elsewhere, and thankfully here in Queensland we were relatively free of that. So she moved to Queensland. She'd been seeing another ophthalmologist for many years, been treated for a long time with very stable glaucoma, and she was on 3 agents in the form of Xalatan and Simbrinza. She had fantastic pressures, 10 and 11, lovely thick corneas, and she was just doing really, really well. But she was miserable, and this was her ocular surface. I know it's a little difficult probably from where you are to pick out some of the details of these images, so I'll just talk you through what I saw on that day. She's got terribly red eyes, as you can see, but in this larger image, you can see that white change underneath the conjunctiva in the lower lid. So she's got subtarsal or subconjunctival fibrosis. And if you look along the lid margin there, you can't pick out the grey line. The grey line has been lost. You've got the furry margin of the keratinized skin moving posteriorly. So she's got posterior migration of the mucocutaneous border. You can't pick out the meibomian glands. They're effaced, they're atrophic, they're dysfunctional, and the bottom right image, it's very hard to see there, but she's got severe widespread epitheliopathy. So she had terribly upset ocular surface, and you can understand why she was not particularly happy. She did have glaucoma, and so very reasonable for her to be on treatment. You can see she's got inferior RNFL loss there. She's got corresponding field loss. But it's not particularly severe. So in her left eye, she's got a superior arcuate defect, but in the right eye, she's relatively pre-perimetric. So do you think this is overtreatment? I've probably kind of couched that in a way I've spoken about it, but what do you think? Hopefully we've got some polling there. What does the audience think? Is this overtreatment? Yes, no, or somewhere in the middle. Surely someone got it right. I think the answer is often much harder than that. You know, there's a lot more that goes into that decision-making, whether this is over-treatment or under-treatment, than what you see on that one moment when they rock up in your clinic that day. So it's a difficult decision to make, and so I think the spread of responses here represents that. Thanks. We could move on to the next slide. But it could well be overtreatment, and in fact, research supports that a great deal of patients are overtreated, particularly those with mild glaucoma or ocular hypertension. Up to 50% of those may in fact be overtreated. And so, you know, we should make some efforts to see whether we can reduce the burden of that treatment. That's hard. Stepping back from some treatment that either you or someone else has already started can be incredibly difficult. And so how do you do that? Well, you need some facts to base that on and some way to make logical decisions around that. And so some of the things, and this is not an exhaustive list, but history is very, very helpful. What were the starting IOPs? If she started at 18 and there was clear progression, then having a pressure of 11 may be very, very appropriate. But if the starting pressures were 35 and they're on triple therapy and there's been no progression, do we really need to have their pressure that low? They may well be very stable at a much higher pressure. What are the risk factors for progression in this patient? CCT obviously is an important one. This patient had very thick corneas. That is a protective factor against progression. But what else? Do they have a history of, a familial history of blinding, glaucoma, other things like that? And last but not least, what is the severity of the glaucoma? We all know that the more severe the glaucoma is, the lower target pressure we need to aim for in order to reduce progression or the risk of progression. And therefore, if you're dealing with mild glaucoma, would it be acceptable to have them at a higher pressure relative to that patient's need? All right, so let's say we've decided that this is over-treatment. Well, what are we going to do about it? Change or stop the drops? Obviously, there's SLT, and then there's surgical options, whether that's MIGS, which is a term I'll talk about more, but it's not a term I use in my practice, and I'll talk a little bit about why, and then other alternative surgical options, trabeculectomy or whatever it may be. So another question, how much are side effects an issue in your daily practice? I think this question was put up when Kathy spoke, but perhaps we can get some polling on this now. Or perhaps not. So for me, side effects are a frequent problem. I think it's probably not quite frequently, perhaps nearly every single patient. It depends how hard you look for it.
I think it's every single patient if you ask them and look for it.
Yeah, exactly. And I think because it's something that's near and dear to my heart, I probably do ask most of my patients. If they're on a topical treatment, they're likely to have a side effect, and it's difficult to get away from that. And those side effects may not be minor. I think it's easy to think that the treatments we have today are effective and with minimal side effects, but some of them may be very severe. The top image here is a lady who, I took that photo 3 weeks ago. She was eviscerated last week. She had limbal stem cell failure as a result of chronic glaucoma drop use, and then developed a persistent epithelial defect, keratitis, and ophthalmitis, evisceration. Very sad story. And that may or may not have been avoidable, but there are some things that we could do perhaps to reduce the chance of that happening to other patients in the future. We all know the influence of preservatives on our patients, but perhaps recognising how much of a burden benzalkonium chloride is underappreciated. As little as 1 drop a day of benzalkonium chloride containing topical agent causes significant side effects and potentially long-term and permanent side effects. It causes long-term and permanent loss of the goblet cells and dry eye symptoms and other ocular surface disease. But equally on the flip side, reducing the amount of preservative-containing agents or getting rid of them significantly improves symptoms and long-term pathology, and you don't have to do a lot to make patients feel and be better. So here's just a reminding list. On the left are all of our glaucoma drops. This is a table from the US, so some of the names are somewhat different, but, you know, I'll just go back there. Oh, sorry. That's just to highlight the fact that they've pretty much all got BAK in them. And if it's not BAK, well, it's something almost as bad. So trying to find alternative options to that is a worthwhile exercise. So in my head, I just have this little list as my backup option, my go-tos. What options do I have that are preservative-free? And if they're not preservative-free, then they're sort of low preservative load. There's an increasing array of preservative-free agents coming onto the market, thankfully both in the glaucoma sphere, but also in many of our other topical agents. Some of them you'll all be familiar with. Some of them require special access scheme approval, but it doesn't take an awful lot of effort to access those nowadays. So I would encourage you to be able to do that for patients and find alternatives that you can swap them to. On the right-hand side of the screen are those that contain non-BAK, so things like polyquad, which is a bit better than BAK alone. And then don't forget the other side effects. I think you're all aware of the common side effects that glaucoma drops may cause, but there are some others that we may not be so well aware of. For instance, libido loss with beta blockers. the CNS depression that the alpha agonists cause, particularly in the elderly or the very young. And as newer agents are coming onto the market, things like Rapazidil, the ROCK inhibitors, they can cause all sorts of things that we're not yet familiar with, like gastrointestinal upset. So again, unless you ask the patient, they won't volunteer these things. So you do have to be a little bit on the front foot, recognizing that even though they don't tell you that they've got the side effect, they probably know themselves and are therefore not taking the drop because they hate feeling tired and depressed and lethargic. What alternatives have we got? Well, SLT, I spoke about this at our last boot camp earlier in the year. I'm a huge proponent of SLT, and it's very safe and effective. So I would encourage you to consider it as an alternative, and whether that's as primary treatment or as a swapping alternative if you're going to cease a topical agent and use SLT instead. I do offer it to all of my newly diagnosed patients as an alternative to topical therapy, and I talk them through the pros and cons and relative risks and benefits of topical versus SLT. It's not a cure-all. It doesn't work for everybody, and you have to recognise that its ability to lower pressure is not that of trabeculectomy. It's that of maybe one drop, maybe two if you're lucky. So you're not going to be able to get them off 3 agents. You might be able to get them off 1, maybe 2. But that may still be a worthwhile exercise in terms of reducing burden of side effects. Alp will talk to you in more detail about surgery and MIGS in particular, but of course there's an ever-increasing array of surgical options coming onto the market. And whilst I can't go into that in too much depth now, I would say that they are worthwhile options. In general, and this is probably the most generalised statement of the whole conference, the risk of any MIGS is proportional to how much pressure lowering you would get. And I don't know if Alp would agree with that. The lower you're going to get the pressure, probably the more involved that procedure is going to be, and therefore probably correlates with risk. But that may be worthwhile. If someone has intractable side effects from all topical agents and you need a very, very low pressure, then it may well be worthwhile considering that option. So let's talk a little bit about ocular surface disease management, or dry eye disease, which I lump together. For those with ocular surface symptoms that present in your practice, how do you manage them? Do you just refer them on, treat them yourself, or just tell them to go to the chemist? Yep. A lot of people tell them to go to the chemist. I'll move on quickly for the sake of time. If I could go to the next slide. So this is a very complicated slide, but it really is to say that ocular surface disease and dry eye has multiple factors, and rather than that being a point to scare you off, it's actually an opportunity to intervene at all of those different points. And we now have the availability to treat ocular surface disease and ocular surface symptoms in multiple ways. So this is how I conceptualize it in my head. At the very center is always remove the inciting factor, but then there are a whole bunch of other things that we can do to improve symptoms. And 2 things that I'll point out particularly for this audience in relation to glaucoma: anti-inflammatories are very important. That used to just be steroids, but there's an ever-increasing array of non-steroidal anti-inflammatories, such as cyclosporin in the form of things like Icurvis, and then Lefitograst is a new agent, trade name Zedra. So these are less risk to the glaucoma patient, causing steroid-responsive pressure eyes. And then don't forget the lids. So treat the meibomian gland, treat the lid margin disease. That's an important part. Have a logical step-ladder approach. Not everything will work for every patient, so have an algorithm. This is just mine. I start at the bottom and I work my way up 1 step at a time, at each point assessing the patient and working out what's working and what's not. So in summary, rationalise treatment where possible. If you don't have to treat the patient with that particular modality of treatment, best not to, because everything has side effects. Use preservative-free alternatives. There's an increasing array available to you. SLT is an awesome alternative as well, and is both effective and safe. Think about surgical options in a risk management sense. Balance it against the need for that patient, and treat ocular surface disease in a multi-pronged fashion and stepwise approach, one step after the other, so that you can work out what that patient needs at any particular point. Thank you. And I'll ask, so I think next we have Aparna to talk about angle closure management.
Okay, so this is a very, very big topic, so we're just going to go through some of the salient points, really. So the learning points we've got here are to identify that angle closure is more of a disease spectrum. We'll go through some of the indications for laser PI and then indications for cataract surgery in angle closure disease. But first, to start off with, let's have a polling question. Is it possible to bring up the question? That's great. So what do you think? In anatomically predisposed eyes, what is the estimated risk of inducing acute angle closure post-mydriasis? Do you think that would be 1 in 500, 1 in 1,000, or 1 in 4,000? Can we have the questions up, please? Great. Okay. Very diverse. That's a good point to start off with. So really, I need to provide a bit more context because it depends on, the numbers are still moving, on which population we are looking at. Great. So in the ZAP study, for example, which looked at the Chinese population and about 900 of them, which is the most at-risk population in the world, less than 1 in 1,000 eyes that were predisposed to developing acute angle closure had that over a year. It's also worth remembering that these were eyes that were actually repeatedly dilated, not just with tropicamide, but also phenylephrine. Then in a different cohort in the Rotterdam eye study, just 2 in slightly over 6,000, and in Baltimore, just 0 in about 5,000 eyes. So as I alluded to earlier, angle closure disease is more of a spectrum that starts off with primary angle closure suspect, where you have 180 degrees of fluidotrabecular contact, but without associated elevated pressure or optic nerve head damage, which can then convert to primary angle closure, where you have elevated pressure and peripheral antistenochiae, which then can convert into glaucoma with characteristic features of optic neuropathy and visual field defects. Angle closure crisis I've listed there, but it's actually quite a different kettle of fish, really. Where you have primary angle closure, you may or may not have glaucoma, but it's the dramatic rise in pressure that's a key feature. So let's move on to a case. 42-year-old hairdresser, Caucasian, optometrist sent her in with narrow angles that appeared to be shallowing over time. She'd been seen by the optometrist from the age of 40, and she hadn't had any symptoms of angle closure. Now, Caucasians, we know, get more symptomatic, whereas Asians don't, because they often get more sort of iris ischemia, which is more symptomatic. She's had a history of amblyopia and patching in her left eye, and she's got a very, very strong family history of glaucoma. Good vision with significant hyperopic correction, normal pressures, average CCTs, and gonioscopy really is key. So the more gonio we can do, the more comfortable we get looking at angles like this. So just describing the angle rather than saying whether it's occludable or not, looking at pigmentation, those sorts of things. Gonioscopy.org is a fantastic resource just to revise gonioscopy. It is definitely a good idea to use anterior segmental CT if you have it, but that can overcall the condition, so gonioscopy. So for her, Schwalbe's line to anterior trabecular meshwork, just visible 360 degrees on gentle indentation, and no evidence of PAS. So classic case of PACS, normal discs and fields looking healthy. So can we have the polling question up again, thanks? So this patient should be observed, prophylactic PI, or clear lens extraction. Yeah, great. No one for clear lens extraction yet. Oh, there we go. Fantastic. Okay, so it's good to go back a step when you're going to observe someone. What is the actual risk of converting from PACS to primary angle closure? Again, quite a heterogeneous group of papers here. Thomas Back and his colleagues back in 2003 looked at a Southern Indian population and found that 22% of their cohort converted from suspect to primary angle closure. More recently, the ZAP trial report in 2019 found that only 1 in 20 untreated eyes converted to primary angle closure. There's Australian data as well, but it wasn't designed to look at this question in particular. So if we look at the ZAP trial results in a nutshell, they reported looking at somewhere almost around 900 primary angle closure suspect eyes, and found that, they randomized them to either receiving prophylactic PI or observing them. And they found that in treated eyes, just 4 of those treated eyes per 1,000 converted into primary angle closure disease. So that was including primary angle closure with elevated pressure or developing glaucoma as well. And in untreated eyes, almost 8 per 1,000 developed primary angle closure disease. So LPI does have a modest but significant prophylactic effect. But if we flip those numbers around a little bit, you need 44 to prevent 1 new case of primary angle closure disease. So is it worthwhile then doing PIs in our entire cohort of, all the patients that come through our clinic with primary angle closure suspect? Probably not. EAGLE trial is actually quite different to the ZAP trial in the sense that they looked at patients that had primary angle closure, so patients with elevated pressure above 30 and with established glaucoma. None of the cases had just primary angle closure suspect. They didn't have a cataract, and they randomized them to clear lens extraction or to standard of care. And definitely the clear lens extraction group did better in terms of quality of life and IOP control. But these are patients who have primary angle closure primary angle closure, and they have glaucoma, or they might have glaucoma as well. But it's worthwhile remembering that there is a risk to clear lens extraction as well. You've got the risk of endophthalmitis, posterior capsular rupture, and don't forget aqueous misdirection in eyes that are already predisposed to aqueous misdirection. So, different case now, 84-year-old Caucasian lady sent in by her optometrist with cataracts, vision of 612 and 618 in the left, pressure elevated in the left eye with slightly thicker corneas. She was dilated on arrival as part of cataract assessment, some nuclear sclerosis and disc asymmetry, with the left being worse than the right, thinning inferior temporally. So she was started on Lumigan at night to both eyes, and the review was set for 2 weeks for a much more detailed glaucoma assessment. She returned 3 weeks later for a pressure check as sort of scheduled, and she said that 2 to 3 days after starting on Lumigan, she really just couldn't see. Her eyes were watery and photophobic. She had headaches, nausea, vomiting, and she went into acute angle closure. So she had an attack, and that was just from that one episode of dilation. So cornea was hazy, pressure of 64, couldn't really go near the left eye. The right eye had no angle structures visible and quite a significant anterior lens vault. So she was treated medically, and once the cornea cleared, had a laser peripheral iridotomy. Her pressure was controlled medically again. She came off Diamox, and her vision went to 624. These are her visual fields and OCT scans. It's worthwhile looking at that biometry because the lens thickness is incredible. It's sort of over 5.5 compared to a very, very small anterior chamber depth. So she underwent cataract surgery a month later, and her vision improved to 6/12, but her pressure was still 20 on maximal medical therapy, which is when I got involved. So cataract surgery and angle closure can be quite challenging, worth deferring if possible for at least a few weeks, because there's a lot of post-op inflammation that can develop otherwise. Of course, there's that risk of aqueous misdirection either on the table or post-operatively. And IOR power calculations can be quite challenging because there's a significant risk of myopic surprise. So can I here make a plug for the SCRIS online calculator, which was just recently unveiled. You can punch in your biometry and you get a range of options to choose from in terms of the newer formulas, which are slightly better for smaller axial lengths. And then there's the issue of IOP control post-op as well. And just to finish off, looking at a Cochrane review in terms of lens extraction for chronic angle closure glaucoma. Now, this is in patients without acute angle closure attacks. 8 randomized control trials. Essentially, it showed lens extraction has an advantage over PI in treating chronic angle closure, which was supported by the EAGLE trial. In patients with visually significant cataract and chronic PACG, cataract is just as good as phaco viscocanaloplasty or GSL, and phaco outperforms doing laser peripheral rhodoplasty. So in summary, angle closure disease is a spectrum, worthwhile doing gonio as much as possible. Identify those eyes that are high risk of angle closure. Widespread PI for PACS is not really recommended, and lens extraction is a very useful tool. Thank you.
Our final speaker is Dr. Alp Attic, who challenges us to whether we should be early adopters. Let's talk about new technology, the minimally invasive glaucoma surgery in 2022. What is the evidence?
Thanks, Kathy. It's a pleasure to be with you all. I'm going to go straight into my talk. So the learning objectives of my talk are to describe the different types of minimally invasive glaucoma surgery, or MIGS, as well as their uptake in Australia, to discuss the evidence behind them, critically appraise the quality of this evidence, and to debate the use of MIGS on the base of cost effectiveness. And I hope you find it all interesting and engaging. So if the first question I'd like to ask the audience is to get a framework of where we're at in terms of MIGS usage amongst us all. So if we could put up the first poll, please. And you can select all that apply in your clinical practice. Okay, so that's interesting. 21% of our audience, or 25% of our audience don't use MIGS. And about 40% are using iStent, and the rest are fairly evenly distributed. Thank you. We'll go back to the presentation. So I break up the different types of MIGS available to us in Australia into whether they're conjunctival involving or conjunctival sparing. The reason for that is because the conjunctiva for glaucoma surgery is very important real estate, because that's where our gold standard incisional procedures are done in the form of trabeculectomies and glaucoma drainage devices. There are 2 types of MIGS available in Australia, the Zen and the PRESERFLO microshunt, which involve the conjunctiva. Amongst conjunctiva sparing options, we have stents such as the iStent and the Hydrus, which bypass the trabecular meshwork, and ab interno canaloplasty through devices like the iTrack, which actually cause trabecular meshwork dilatation, and then gonioscopy-assisted transluminal trabeculotomy, or GAT, which causes destruction of the trabecular meshwork. There's been a stunning uptake of MIGS in Australia in the past 4 years, with a 4-fold increase of trabecular bypass at the time of cataract surgery, which has gone up from about 2,000 item numbers billed per year to over 8,000. Standalone MIGS was introduced in 2020 and has seen a slow but steady rise in its uptake as well. It's difficult to assess the uptake of subconjunctival MIGS because the item number applied to it, 42746, is the same as that of trabeculectomy, but we do see a sharp uptake between 2017 and 2019 and then a plateau thereafter, as you can see on there with the green line graph. And at the bottom of that chart is the glaucoma drainage device implantation, which has stayed fairly stable in the last 5 years, as you can see by the light blue line. Now, breaking down 42746 or filtration surgery a little bit in more detail in Australia, we see that the mean annual item number use has increased by 32% in the last 5 years, so between 2017 and 2021, compared to the preceding 5 years. This is transmitted into an increase in the mean annual benefit paid by Medicare by 34% in the last 5 years compared to the preceding 5 years. So what does this all mean? I'd like to bring everyone back to the basic principles that we need to look at before we adapt a new treatment, especially if it's going to disrupt standard care. So when we have a new treatment emanating as an option for standard care, we need to make sure that it is safe, we need to make sure it's effective, and we need to make sure that it's cost effective. And in order to do this, we need evidence or data. And you'll remember this pyramid as the hierarchy of evidence. This is what we base our quality of data on in medical practice. At the bottom, we have case series or case reports and editorials and expert evidence. And according to the hierarchy of medicine, that is not evidence. In the middle, we have cohort studies and case control studies, which are considered as low-quality evidence. And at the top, we have systematic reviews and randomized controlled trials, which are considered the gold standard of evidence. So when we look at the quality of the evidence when it comes to trabecular bypass in the form of iStent, we see that 4 RCTs, or randomized controlled trials, have been done comparing iStent with cataract surgery to cataract surgery alone. All of these trials received company support, and a Cochrane review was released a few years ago doing a pooled data analysis of the outcome of these studies and found that iStent at the time of cataract surgery had a 1.38 times the likelihood of being drop-free compared to cataract surgery alone, and these patients were on about 0.42 fewer drops. But when we look at the quality of the data, we see that only one of those 4 studies randomized patients appropriately. Only one of those studies were appropriately blinded. Only 2 had completed outcome data, and 3 did have non-selective reporting. Similarly, when we look at the quality of the evidence behind the Hydrus, we see 2 RCTs that are comparing Hydrus at the time of cataract surgery with cataract surgery alone. Again, both studies received company funding. Another Cochrane review was done, which showed on pooled analysis that patients who had Hydrus at the time of cataract surgery had 1.59 times the likelihood of being drop-free compared to patients who had cataract surgery alone, and were on approximately 0.41 fewer drops. Both those studies were actually appropriately randomized, but again, neither of them were appropriately blinded. So investigators knew when they were checking the pressure that this patient had received a Hydrus and this patient hadn't. One had completed outcome data and one had non-selective reporting. So overall, there is evidence for trabecular bypass in the form of RCTs, but it's not perfect. When we look at subconjunctival microstents like the Zen and the PreserFlow, we see that in the case of the Zen, there is no published randomized controlled trial comparing Zen with trabeculectomy. One called the Gold Standard Pathway Study was completed in 2018, but there is no peer-reviewed published data. So we're currently basing our practice of Zen implantation on retrospective and prospective cohort studies. There was a randomized controlled trial done on the PreserFlow microshunt, which was a landmark paper published in Ophthalmology, comparing it to trabeculectomy. In terms of IOP reduction, it was about 3 millimeters mercury less. The PreserFlow had a higher failure rate of 41.6% at 1 year, higher needling rate, higher reoperation rate, and after 3 months, a higher rate of raised IOP requiring treatment. And all of those differences were statistically significant and also clinically significant. So the overview of the MIGS literature is a heterogeneous array of studies because of the fact that we don't have a standardized guideline on the way we report the outcomes of MIGS trials. Out of 3,069 studies, only 0.29% are randomized controlled trials. 46% of studies only adhered to the WGA guidelines, and blinding was performed in only 40% of them. At least one author had industry association in 64% of studies, and 90% of the randomized controlled trials were industry funded. And now we move on to the cost effectiveness of these MIGS devices. So there has been some work done on this, and the overall consensus is that both the Hydrus and the iStent are cost-effective treatment options. On the left is a cost-effectiveness acceptability curve that looks at the probability that an iStent is going to be cost-effective at various willingness-to-pay thresholds. And a willingness-to-pay threshold is how much society is willing to pay for a patient to gain one quality-adjusted life year or QALY. In Australia, we use about $50,000 per QALY as our willingness-to-pay threshold, and you'll see that the probability that the iStent is cost-effective is about 90% over the course of a patient's life. Another paper was published on the cost-effectiveness of the Hydrus, and it introduced another variable called efficacy rate to differentiate trial data from real-world outcomes. And it showed that for the Hydrus to remain cost-effective in the real world, its efficacy in terms of IOP reduction and the number of glaucoma drops needed to be at least 85% as effective as the trial data. So if it was only 80% as effective as the trial data, it was not a cost-effective treatment option, and cataract surgery alone was better. Things get even more interesting when we look at the cost-effectiveness of subconjunctival microstents. A paper was conducted looking at the raw data from that randomized controlled trial I was telling you about, and showed that the microshunt was economically dominated by trabeculectomy, which means that it had higher costs and worse outcomes than trabeculectomy, even when the device fee was $0. A probabilistic analysis running that simulation 1,000 times was also performed on that data, which you can see here on the scatter plot. The black triangles are all the non-cost-effective iterations in that analysis, and the white circles are the cost-effective iterations. So that data showed that there was a 78% likelihood that patients receiving PreserFlow will have higher costs and worse outcomes compared with trabeculectomy, and that the likelihood of microshunt being cost-effective is 6.4%. So my take-home points are that as clinicians, it's our responsibility to critically appraise all emerging technologies to ensure that they are safe, effective, and cost-effective, and the burden of proof must be overcome prior to widespread implantation. I challenge all of us to perhaps change a culture driven by being the first to do something into being the best at performing the proven treatment. And don't get me wrong, innovation is incredibly important, but a minimum standard must be met prior to implementation on patients in clinical practice. Thank you. And I've just got one more poll here, if we can potentially put that up. And I'm hoping to have convinced you all. No luck. Thank you. Maybe it's better, I don't know.
So we've taken you on a bit of a tour from clinical practice to glaucoma evidence to finally the world of health economics. And I'm now hoping to take you to another world I inhabit from time to time, which is education land. If I could have my final slides. Instructional design and interactive learning have become more important in the last couple of years because so much of our world has become online. But these are basic principles that can be applied to any teaching and learning activities you undertake. The aims of our course were to provide a practical and case-based refresher on diagnosis and management of glaucoma, but also to demonstrate what we hope are examples and formats and tools that promote adult learning. You are all adult learners, and when we were designing this symposium, we had this very much in mind. We know that most people who attend this conference are general ophthalmologists or trainees. We also hope for some cross-fertilization with other subspecialists, because glaucoma is a disease that crosses all subspecialties, and you'll all be seeing glaucoma patients. So we start off, well, why do you need to know? And I opened up with that case, a very real case of a patient who went blind on our watch. We're problem-oriented as adult learners. We want to solve problems. We are motivated. We're ophthalmologists. We want to prevent people from going blind. You are in charge of your own learning, but you also want learning that is just in time, and we hope something that when you walk out of here today, you learned some things that you will apply when you go back to work tomorrow or on Wednesday or Thursday. Gagne described 9 events of instruction. The first is to gain attention. We also then need to inform people of why they're here and what our learning objectives are. That orientates people to the content that comes. We need to connect that with prior learning. Adult learners usually come with a lot of experience. We then present the content, but we also provide guidance as that goes on. When you leave here, we hope that you will be practicing this. And if this was part of a course or an online module, we would also hope to provide some feedback and some assessment tasks so that you know you can do. Again then, the final thing would be to enhance retention and transfer and ensure that this is being transferred to the job that you're doing. I'm not sure if you're all familiar with how your energy levels are in a traditional hour-long lecture. We know that in the first 5 to 10 minutes, attention is high, and then it drops right down and stays right down until someone starts to say, and in conclusion, everybody wakes up and thinks about the next thing that they're going to do. The attention cycle is 10 minutes. When I'm looking online, my attention cycle for an online video is about 2 to 3 minutes before I look bored. It is no accident that each of our presentations was 10 minutes. But also, we try to reset your attention in between by getting you to answer questions that are relevant to your practice, but also relevant to how effective our talks were going. So 10 minutes reset. We hope you woke up at each time. I know some people might not have, but I wouldn't take that personally. When designing your content, think about cognitive load theory. There's 3 aspects to this. Sorry, move back. Extraneous load is the stuff that distracts you and is unnecessary and just inhibits your learning. Intrinsic load is the complexity of new information, and the germane load is how you connect the new information with the old information. To reduce cognitive load, it's important to include only relevant content, so the must know, not the nice to know. It helps to have clear objectives with chunking and signaling, and we did that by having learning objectives at the beginning, but also reminding you as we went along where we were in that process. It's really important to try and avoid distracting graphics or a mismatch between your content and what people are seeing. So if you have a picture that's not relevant to your content, it can be very distracting. We also know that people learn better when using both visual and auditory channels. And just take a moment to read these letters. How hard is it to name the colours if there's some dissonance? Then there is the forgetting curve. So unfortunately, even if you've been paying attention, your attention has been high, by tomorrow you will have forgotten about 50% of what we said, and in a week's time you'll remember less than 20% of what we discussed. So the way to increase retention is to use spaced repetition. So just when you're starting to get to the bottom of that forgetting curve, if you are sent a prompt or a reminder of what you learned, that will improve your retention. This is very helpful for trainees as well. So if you're studying, go back and revise what you did a few days before. This is a book I recommend to everybody who likes to teach and learn. It's called Make It Stick, and it's a really great, it goes in a lot more detail of this. The other thing is to mix it up. So instead of just doing one topic at a time, even though it's more difficult and more challenging, if you mix up what the content is, it actually improves retention. So this is the flattening the forgetting curve. So, sorry. If I were to send you a nudge in a couple of days, you might remember more. And a week later, you might get that. And then a few weeks later, if you get a quiz or something online that helps you revisit this, your forgetting curve will be less. If you have the opportunity to have time to prepare for lectures or tutorials, it's helpful to use the flipped classroom. So get your learners to revise the literature, read the papers beforehand, so that during your lecture or your tutorial, you're using that time for discussion and promoting understanding. And then afterwards, check in with them with a quiz or some sort of reminder that allows them to revise that, perhaps with some additional reading. In terms of interactivity, there are lots of audience response apps, which we've tried today. There are different ways of doing that. There's a word cloud, so you can pose a question. We did polling, and there's also a great app, which is a quiz to make it fun, and you can have a prize winner. These are some examples of the apps that are available. We specifically chose to use the polling app at the conference because we wanted certainty and consistency with the AV. You've been here for a few days, so your cognitive load would be less because you're already familiar with the app. It also reduces our cognitive load because we don't have to worry about whether it's going to work or not. If you don't have access to polling, you can use classroom techniques such as show of hands, coloured cards. You can ask people to think about a question and then share it. You can have a 1-minute write, pose a question, get people to write some notes. Question of the day, groups, buzz groups, crossover and snowballs. These are much more useful in group learning activities. As I said, these two references, which are really useful. And then we're coming to the final part of this session before we go to Q&A, which is getting back to glaucoma land. So our take-home tips and requests of you are to try and avoid both over and under treatment, monitor for progression at appropriate frequency and adjust your target IOP based on new information, and you might need to do that several times during the course of the patient's journey. Don't rely on OCT alone. Know when to hold and when to fold. Think about surgical intervention if there's maximum medical treatment and progression, or if the patient is intolerant of drops. And try and perform fields often enough for that individual patient. So low-risk patients that you know are stable may be fine having a field once a year. But if they're fast progressors, you don't want to miss that opportunity to prevent them from losing vision permanently. As Nick highlighted, don't underestimate the morbidity of topical medical treatment and have in mind to reduce ocular surface disease. I was rather afraid that that patient you presented might have been mine because lots of my patients moved north during the pandemic. Continue to do gonioscopy to detect angle closure, and I was very heartened by the response to that question. And then finally, try and apply education and learning theory to planning and delivering your teaching. And I challenge you to experiment with some of the tools available to promote interactive learning. Try one at a time, see which one you like. So it is my pleasure now to invite you for Q&A. Alp will be monitoring the online questions, but we also have some microphones for the audience if you'd like to ask some questions of the panel. In particular, Janie, who we let off the hook in terms of giving a lecture, but we're very welcome to have her on the panel.
I've got some questions here, Kathy, as live Q&A on the app. And I'm just going to do it in chronological order. So the first question I think is directed to Bernardo. What is the age-related rate of change of inner retinal thickness as measured at the macula?
I might bundle that with a follow-up question as well, that they ask what the rate is for neurodegenerative disease.
Yep.
So for those who have obviously mentioned the retinal nerve fiber layer rate of the average one, not the segment one. So for the ganglion cell complex, and as for those who use Heidelberg, the Brooks membrane opening, medium marine width, there's not a well-established follow-up. Those are newer, relatively newer parameters. So we don't have an answer for that. With a macula, though, there's a lot of confounding defects, even though in myopsy can be particularly helpful at the start. We always get more artifacts with epiretinal membranes, choroidal neovascularization, staphyloma, and so on. In particular to neurodegenerative disease, again, because it is a very difficult diagnosis to make, there's no biomarker, it's very hard to assess when the patient actually has been diagnosed, at which stage they are. In that case, I would advise you to liaise with their GP or neurologist about what's the rate of progression, what's their life expectancy, what level their neurodegeneration is at, because that will affect their cognition, including what type of treatment you're going to offer. If they're progressing at around the aging rate or slightly above, that might be acceptable. If they're going down 3-5 microns a year, then they might require intervention, but obviously that has to be on a case-by-case basis.
I've got another question here for Nick. Why aren't more people putting in preservative-free drops if BAK is so damaging? And can patients access preservative-free latanoprost and timolol in Australia?
Sure. I think there's sort of multiple answers to that. One of them is that we all change our practice slowly, and so things that we've done in the past are the things that we tend to keep doing. But as more options become available, we'll start to do those things over time. And then secondly, the sort of major barrier, I think, to preservative-free drop usage is often our patients' ability to put the drops in. So they're often older patients, and minims are difficult to use for the arthritic or older patients, so that can be a limiting factor. And again, technology and time will help that as bottled preservative-free options are becoming available. Can you get preservative-free latanoprost in Australia? My understanding is you can. I've seen a couple of patients on it come from other specialists. I've never actually used it, but if there's anyone else that has prescribed it here in Australia, I think you can get it through the Special Access Scheme.
I have a question for Janie. So the experience in Australia with MIGS is probably quite different from in the USA. Do you have any comments about the evidence base and the introduction of new technologies and the threshold with which we adopt new technology?
Yeah, thank you. First of all, I'd just like to congratulate the panel on a great presentation and great teaching. I really enjoyed it a lot. I think that probably in the US, it's not that different in terms of how we adopt new technology compared to, here in Australia. We have the same concerns that obviously, it's really hard to argue against safety. And knowing that, you're doing something new to a patient that is, you certainly don't want to do any harm. And then I think obviously cost effectiveness is important, but I think what glaucoma specialists are really looking for is using the approach that is going to get them the result that the patient needs. And so, I thought it was laid out really beautifully today, but, some patients need to have more pressure lowering than you're going to get with some of the MIGS procedures. And, and those patients are going to need a more bleb-related procedure. So, I think that's the answer.
Alp, are there any more?
Do we have any live questions, or should I keep going through the app? We'll go down the app then.
People are scared of those steep stairs.
Aparna, what is the incidence of acute angle closure glaucoma in eyes with a patent laser PI? And I'll follow that up with, should we do goniosynechiolysis when performing phaco in all eyes after acute angle closure? So incidence of acute angle closure, well, I think it's, acute angle closure in eyes with patent PI, and do you do goniosynechiolysis in patients who've had acute angle closure?
Okay, so this was one slide that I really wanted to add in, but I couldn't because of time constraints, is there are a number of mechanisms for acute angle closure. starting from anterior to posterior, sorry, it's a long-winded way of answering the question, but you've got pupil block, but there are lens components as well, and then there's anterior rotation of the ciliary body and vitreous as well. So remembering that PI only addresses the pupil block component, which is, yes, the majority, but 25% of cases that have angle closure are not because of pupil block. There isn't a specific number like what I raised for primary angle closure disease, but I guess it's just a case of waiting for the ZAP trial results to come out and give us some numbers.
And what about goniosyneculasis with cataract surgery in patients who've had acute angle closure?
So from the literature, we do know that GSL tends to work better if it's performed within 12 months of the PAS forming. Now, I don't know how we can figure out by just simply looking at PAS when they have formed, apart from, if you sort of do serial gonios. I don't routinely perform GSL unless I've followed the patient up for a period of time, because there is to GSL as well, particularly with high FEMA post-op. I don't know what everyone else does.
No, I would agree with that. Plus increased iris manipulation, increased post-op inflammation in CMO. It tends to be less effective than just doing the phaco. And if you have a compromised angle, then you're trying to replace that outflow with a filtering procedure.
Kathy, I might ask you a question. It's from the audience. What are your recommendations or tips for target pressure setting in patients with normal tension glaucoma?
Normal tension glaucoma is a tough one, and I don't think we fully understand what it is or whether it's just primary open-angle glaucoma. When I set a target pressure, I always think of the pressure at which the diagnosis was made. Obviously, we always aim for at least a 20 to 30% drop in IOP when we've diagnosed someone with glaucoma. One also takes into account corneal thickness, the age of the patient, and the amount of glaucomatous field loss there is. In normal tension glaucoma, I always try to go as low as possible, but weighing up the morbidity and the invasiveness of my intervention. And if we've got to a point where we're not winning, but we're not sure whether the patient is going to progress, I will then monitor much more closely for progression and perhaps increase the frequency of the field testing to perhaps every 2 to 3 months, even though the item number doesn't allow that, or your patients may be out of pocket, or you may be out of pocket. But you need to establish your rate of progression, because we know that if you only do a field test once a year, it may take you 6 years to confirm whether a patient is progressing. If you do 3 fields per year for 2 years, you will know whether the patient is progressing or not. And our job is to find the fast progressors. And I just remember a comment made by Anders Hale at the last Angis conference, which is that we're looking for progression in early disease, but sometimes what we should be looking for is the always what we should be looking for is the fast progressors. And those people who are going to go blind if we don't detect them. So a long answer to a complex question.
I think we probably have time for one more. I might open this to the panel, but perhaps, Bernardo, you can take lead, because it's sort of in relation to what you were talking about. There has been little comment to GCL monitoring. Please give update as to its usefulness and any comments on the utility of OCT of the angles. So GCL and OCT of the angles.
So I'll do the GCL and I'll refer the angles to a partner. So we've glaucoma with GCC and GCL, essentially sort of like it's a very useful tool, but it's one of the 3 parameters that we use. And like I mentioned, we have to combine all of them. So in particular, if you have...
Can we just define those first, GCC?
Yes. So ganglion cell complex, which is essentially referring to the macula, the retinal nerve fiber layer around, which is the rings around the disc, and the Brooks membrane opening, which is specific at this stage with the Heidelberg machine, which is 48 points around the disc, looking at all the nerve fibers going into the nerve at that point. So all those three parameters, so if you're looking at two, are useful to follow up over time. Sometimes in myopes, you're going to have tilted discs and peripapillary atrophy, so the ganglion cell complex can be more useful. However, you can have macular changes in those patients, like I've mentioned. If you compare RNFL versus ganglion cell complex, they are similar in detecting early and moderate glaucoma, but better if associated. In advanced glaucoma, probably retinal nerve fiber layer is more useful. And I'm referencing a study that looked at how effective their diagnosis was within a greater area under the curve for those advanced patients.
OCT, so that's a great question. If you have access to anterior segment OCT, it can work in synergy but not replace gonioscopy, unfortunately. The same issues that apply to gonioscopy also apply to OCT. You have to darken the room. You can't sort of, light will call the angle. We also don't have a normative database for OCTA. Agreed, we don't have a normative database for gonioscopy as well. But those are sort of the issues that are involved with using OCTA. Having said that, it can help pick up things like how significant the anterior lens fault is. It can also help in cases of differentiating or figuring out whether this is aqueous misdirection or not. Sometimes aqueous misdirection can be very difficult to diagnose because it turns up so many years later. So it's useful to assess whether just the peripheral angle is shallow or it's sort of uniformly shallow, and I think that's where anti-segment OCT really comes in. I don't know if this is...
I think it's great to convince patients that don't want a PI, even though we feel like we're doing that a lot less often now.
Yeah.
Thank you. I'd like to finish off by thanking you, the audience, for coming and for participating in the polls. I would like to thank the organising committee for giving us the opportunity to present our second boot camp. I would like particularly to thank the AV support people and Maki, who was the person helping us with the polling. The technical support at this conference this year has been amazing. And finally, I'd like to thank the speakers for a really enjoyable session, and in particular Janie for attending.